tonight's guest is Associate Professor Gavin Marx. That's very impressive, isn't it, Associate Professor? I think some of you have heard Gavin before. Gavin is a medical oncologist with a practice here and at French's Forest. He's currently the director of the Sydney Haematology Oncology Clinical Trials Unit. I had to read that, I couldn't remember it. But also, I think you're involved with the Integrated Cancer Centre at the hospital, and I thought you might just give a little insight into what that is. And perhaps can you give us a little insight into NHOG as well as your presentation. I think some of the people might be interested with some of the things that are going on at the hospital here with all this building and the other activity here. So thank you very much. If you put your hands together for Gavin Marx, please.
All right, well, thank you very much for inviting me again to give a discussion about castrate-resistant prostate cancer and a perspective in 2013. I may spend a bit of time at the end of the talk discussing some of those things you asked me to talk about as well, because I think they are some very important things and something that we could be very proud of about what we're trying to achieve here at the SAN. But what I thought tonight we would do is go through some of the issues regarding castrate-resistant prostate cancer and look at a perspective in 2013. Whenever I prepare this talk, I go back to my previous year talks just to have a look at what I said last year, and importantly to see how things have changed in the preceding year. And I looked at the talk that I gave. The first time I was asked to give a talk here was in 2005, and I looked at my talk at that stage, and I had 16 slides, and probably about 2 of them were really meaningful slides. The rest of them were a bit of buffing and trying to make a talk out of something. And now in 2013, I'm going to struggle very hard to finish this in 45 minutes because there is it's just been overwhelming what's happened in this entity of castrate-resistant prostate cancer as far as treatment options. So I think we've seen dramatic changes in the last few years, and it's been very exciting and a real privilege to be involved in some of the studies which have resulted in some very positive outcomes and access to drugs for our patients today. So I think we should just understand what we mean by castrate-resistant or hormone-resistant prostate cancer, and we'll talk about that a bit later. Prostate cancer trials have really taken off in the last few years, and there have been a number of positive studies which have really changed the way we treat this disease. And prostate cancer was really very much ignored until early 2000 and was really very much second fiddle to other diseases such as breast cancer and lung cancer and bowel cancer. But there were a number of reasons for that. And one of the main reasons was that it was very difficult to do clinical trials in prostate cancer. And the first was that in oncology, we like to be able to measure something getting bigger or smaller. And that's how we look at response rate and whether a drug is effective or not. And because prostate cancer is predominantly a bone-related disease, it's actually very hard to measure how things change on a bone scan. So it's been very difficult to use those endpoints that we normally use in other tumors where we can see a lump getting bigger or smaller. And so that made it difficult. The other thing that was difficult was that what we used to use as a surrogate marker was PSA. And as I'm sure most of you are aware, that your oncologists are not quite as addicted to PSAs as patients are, because there are a number of problems with PSA as a surrogate marker. And so there were some issues with that. There have been some very clear definitions of what PSA progression and PSA response are since the PSA working group has redefined that. So now PSA is an important component, but really only one component amongst a number of other things that we look at in prostate cancer. Probably the most important thing to appreciate with prostate cancer, and this would really be my key take-home message, is that prostate cancer is a heterogeneous disease. There's a whole spectrum of disease with prostate cancer. Some people have very low-grade, biologically inactive, slowly grumbling disease that's never going to cause them a problem, and other patients have very biologically active, aggressive disease that if we don't do something about it straight away, there'll be problems. And it's that whole spectrum. But unfortunately, when we look at prostate cancer, we talk about that whole group, and it's including all of those entities. And it's very important, and really the take-home message is to understand the heterogeneity of this disease. And that's what your doctors will be doing, looking at a whole lot of biologic features to try and tell us whether or not this is a disease that we can just sit on for a bit or a disease that we need to treat straight away. The other thing to know is that generally it occurs in men who are a bit older and have accumulated a number of other illnesses along the way which act as competing risk factors. So if there's cardiovascular disease or other medical problems, that may be a competing risk and be more of a problem to the patient than the prostate cancer would be. And the other thing that comes with comorbidities is that their lungs, their liver, their kidneys are not as well able to tolerate various treatments that we would recommend. So all of those factors need to be taken into account. So it's not just one disease, it's a whole spectrum. And as you can imagine, doing clinical trials when you've got that whole spectrum is quite difficult. Everything changed with the development of Castrate, which we'll talk about a bit later, which is the first chemotherapy that actually showed that if we treated our patients with this drug, there was a survival benefit. And once that happened, there was a whole lot of excitement in research saying we can actually make a difference to this disease, which was the first time that we'd seen that, aside from using hormonal treatments. And then in 2010, we had a very big year where there were a number of positive studies. And now, as a result of that, there are a number of new treatments and a number of clinical trials that are either just closing or open, where patients can enroll into those studies and be able to access some of the newer drugs that are just coming onto the market. It's important to understand that prostate cancer is a big problem in Australia. Over 18,000 men are diagnosed each year, and of this, 3,000 will die. And some of them are young as 45 years old. Now, previously the perception was this was a disease of older patients and nothing really happened to them. They usually died with the disease rather than of the disease. Now there's certainly a significant component of patients who never run into trouble with their prostate cancer, but what we need to start doing is understanding who are those patients that are going to run into trouble if we don't do anything about it. And it's important to appreciate that this is the same number of people who run into trouble, actually it's more, than that run into trouble with breast cancer. So it's a significant problem and it deserves the attention it's getting. And certainly groups like the PCFA and these support groups have been instrumental in changing the interest and the drive to encourage research in this field. So this is just a continuum or a spectrum of what prostate cancer is like. So people, they come up with the diagnosis, and that's changed a bit of late, usually with the PSA screening, which is in itself a hugely controversial area, and we're not going to be discussing that tonight at all, because we really would be here till midnight. What happens is patients are diagnosed with prostate cancer, usually with an elevated PSA, and then they would have localized treatment, either surgery or radiotherapy. And again, we're not going to spend much time talking about those local treatment options. Now, for some people, that will be the end of the story. There'll be no other problems, the disease will be cured. But in other patients, after a period of time, the PSA starts going up again, and then we can look at some of the options that we have to treat those patients. And the main option that we use at that stage would be hormone treatment. And after that, that will work for a period of time, and then it stops working. And then we've got this opportunity to carry on with some hormonal manipulation, but more importantly, this is where we talk about patients being castrate resistant. In other words, the level of testosterone has been completely suppressed, but the disease is still going on. Now, what we can do in that area is the area where there's been the most excitement, and this is this area of castrate-resistant disease. Now, even within castrate-resistant disease, there's a whole spectrum of disease. And that ranges, firstly, from patients who have what we call M0 disease, in other words, no evidence of metastases, but we know that there's something brewing or they're tiny microscopic cells, and that's a very different patient group to the patients who've got established metastases. But even in the patients with established metastases, there's a wide spectrum of disease as well. So this is just kind of a continuum, and this is the area that we're going to be concentrating on tonight. Mainly those people who've got established metastases, but also touching on what we do with those patients where we know the disease is brewing, and can we justify or look at some other treatment options in that setting. So we talked about what happens in the disease. It's castrate sensitive, then moving only to people who've got PSA only rises, then what we do when patients have castrate resistance and what we can do to try and treat that. And one of the very interesting things that we'll do, I'm not going to spend a lot of time on hormone treatment, is this concept of antiandrogen withdrawal. What happens with prostate cancer is that prostate cancer is driven by testosterone. And testosterone predominantly comes from the testes, but you also get a small amount that's produced from the adrenal gland. And what a number of the hormone medications we use, the injections we use, is to reduce the testosterone level. But you still do get a little bit of testosterone coming through from the adrenal gland. And that's when we use some of the tablet treatments to block the receptor, to try and block the adrenal gland secretion of testosterone. But after a while, the prostate cancer cell gets very clever and actually mutates or changes the receptor such that it actually starts using those anti-androgen drugs that we've prescribed to act as a testosterone surrogate and make the tumor grow. So one of the interventions that we can use is to actually withdraw that drug. And by withdrawing that drug in a proportion of patients, we'll get some response. Now, that's one modality that we can use in people who are becoming castrate resistant. And that's only relevant for certain diseases and depends on the biology of the disease and the nature of the disease. But that's one of the things that we can do. The next issue is what we do before patients have treatment with Taxotere. And this is an area of significant research at the moment. The backbone of treatment, though, is to use this chemotherapy drug called Taxotere. And then the next question comes, well, what do we do after Taxotere? Once Taxotere's worked for a period of time, what are the other treatment options? And those are some of the things we'll touch on today. This slide just looks at some of the options that have happened in the last few years. And the main message that I want to let you take home from this is that there are 3 different modalities or 3 different ways that we can now approach this disease of patients with castrate resistance. The first is to use a new and different type of chemotherapy, and we'll talk about that agent. The second is to use other hormones, so take advantage or exploit other things that are happening with hormones. And the third is to use immune therapy. And that's a little bit of a controversial area, but it's a proof of principle, and it highlights another mechanisms that we can intervene in trying to deal with this disease. So I've alluded to this drug called Taxotere or docetaxel, and that was really the first chemotherapy that demonstrated a benefit in patients with this disease. And what we do whenever we're doing clinical trials is look at what is the standard of care at the moment, and then compare it to the new drug we're looking at, we compare that to what is considered the standard of care. And at the time that this study was done, the standard of care was a combination of drugs called mitoxantrone and prednisone. Now, this had very modest benefits, but it did have some quality of life benefits. And at that stage, that was really the only treatment option that we had for our patients. So this was a large international randomized trial. A number of Australian centres were involved in this study, which compared 3 drugs, 3 weekly Taxotere, or the old standard drug, mitoxantrone. And what this showed, these are slides that we use all the time in oncology, comparing 2 treatments. And if you can slide your pointer between there, it tells you that the one treatment is better than the other. And what we've seen for the first time in prostate cancer with this treatment was that there was a survival benefit. That by using this drug Taxotere, people did better than if we just used mitoxantrone. And what it showed was that there was a better survival, but not only was there better survival, one of the other things that's very important in this situation is to try and also make people feel better, despite the potential price that you pay from a side effect point of view. And so one of the things that we also need to look at is how it affects the pain, how it affects the quality of life, and how it affects patients' overall well-being. And what this study showed was that not only did it demonstrate a better survival outcome, but it also showed improvements in the other important modalities: quality of life, pain control, and also PSA response. Another study was done at the same time of this study, which really reinforced the results that we were seeing with that study. And so overall, we had 2 pivotal trials showing that by using Taxotere, we improved patients' outcomes, and overall patients did better both from a survival and quality of life point of view. And this changed the standard of care, and this became what we used as our standard treatment for our patients. It's a but, and a very big but, probably could be even bigger. It's not relevant for everyone. Taxotere is an effective drug and it's an active agent, but it's not relevant for everyone. And we've got to weigh up the risks and benefits on an individual patient basis. And this is one of the important factors, is that patients would always say, oh, my friend had this, and why is he having this treatment? Why am I? It's a very different disease. And even in our discussions, when we come to question time, I'll always have someone say to me, well, you know, my prostate cancer is this, my PSA is that, what should I do? I have no idea. Without knowing the whole story, the whole Gleason score, all the factors about the disease, you can't make a comment. So it's important to know that Taxotere is a useful agent, but it's not for everyone. And we've got to select the patients who are most likely to benefit from that treatment. And it does come with some side effects, and those side effects need to be weighed up, whether a patient is able to tolerate those side effects. And what we're really trying to do now with most of the research is look at some of the biologic factors that are able to help distinguish which patients are most likely to benefit from which drug. And so that's becoming an important part of treatment. So Taxotere is a very useful option, but not for everyone. The important thing about Taxotere coming to the market or showing the survival benefit in the trial was that it changed the landscape for how we looked at prostate cancer. All of a sudden, there was a lot of enthusiasm and excitement in trying to look at treatment options for our patients. The next question came about, well, if Taxotere works, why don't we do Taxotere plus something else and see if we can do something even better? And then we also looked at, well, what do we do if we know that Taxotere works in the first-line setting? What are we going to do when Taxotere stops working? And that opened up a whole lot of avenues for research. The next thing that we start looking at is say, well, if Taxotere works in advanced disease, can we do things to bring it earlier and use it earlier in the piece? Would that make a difference? And those are some of the studies that are ongoing at the moment. And so one of the very big questions in the management at this stage is, when do we actually use the drug? What's the right time to use it? What are the factors that predict now's the time to start this drug, or when is it more appropriate to sit and just wait? And obviously the most important thing is to try and select the right patient for the right treatment. So I've already alluded to the fact that we know Taxotere works, and as oncologists we say, well, if one works, let's add two, see if that makes a difference. And unfortunately in this field, whatever we added to Taxotere didn't improve the outcome. So there were a number of studies that were done looking at a whole lot of different targets and a whole lot of different agents and a whole lot of different avenues, and we said, well, Taxotere plus X, Taxotere plus Y, plus all these drugs that I've mentioned here, didn't actually improve the outcome. And in fact, when you added another drug to Taxotere, the outcomes weren't any better, but the side effects were worse. And so on that basis, at the moment, an addition of something on top of Taxotere or using a combination treatment is not an accepted treatment. But what is important is that we're now looking at sequential treatment. So we know that combination probably doesn't help with the agents that have so far been tested, although there are a number of other drugs that are still being looked at. What can we do using the treatment sequentially is now the important question. So what went wrong? We used a whole lot of targets, and one of the problems with targets is that you've got a rough idea of the target. If you don't know exactly what the target is and you don't get the fit exactly right, it may not work. And that may have been one of the problems with some of the Taxotere combination with targeted treatments trials, is that we didn't have a very clear understanding of that particular target. And that's an area of ongoing research. But at the moment, the combination of Taxotere and some of these agents is not the way to go. So there has been a lot of progress, and what we're going to talk about now is what the next line of treatment beyond Taxotere. Now, the first agent that was shown to be effective after Taxotere in the second-line setting was a different type of chemotherapy drug called Cabeza Taxol, and then there was a whole lot of interest in modifying the hormone receptor. So what we started to do is appreciate that the hormone receptor wasn't just as simple as I explained in the beginning, which is a receptor that's waiting for testosterone to land on it, and the options are to reduce testosterone, as we do with the LHRH agonists, which are, you know, the Zoladex and Leucrin and all the 3-monthly injections, or to block the receptor with the various oral agents. The androgen receptor is now understood to be a much more complex and interesting area to potentially target. So that's where these hormonal treatments come into it. And then we'll also just spend a little bit of time talking about some of the immunotherapy options, more so because it opens a whole lot of another avenue for research and leads us onto some of the clinical trials that we're trying to do here. So talking about Cabeza Taxol, this is the new treatment beyond Taxotere, and this is a new drug similar to Taxotere, but just with a slight modification, and generally is a better tolerated agent than Taxotere. And an important study was done looking at whether adding Cabeza Taxol is better than an old standard of mitoxantrone. So patients had Taxotere first. When that stopped working, we looked at either switching to Cabeza Taxol or the old standard of mitoxantrone. And really what this showed is another survival curve, which again shows an improvement. So when we use Cabeza Taxol instead of mitoxantrone, patients do better. And this was a very important study that was done internationally, and some centres in Australia were involved as well. And as a result of this study, Cabeza Taxol is now, or another, also known as Jevtana, is now available in Australia for treatment beyond Taxotere. So when the Taxotere stops working, there's the option to use this agent, Jevtana. So what we saw with this agent is that it improved survival. We know that the side effects were manageable. It was very important to try and pick the right patients for this disease. And we know that it works in people even when Taxotere has failed. So if Taxotere has worked, we know these patients get a benefit. But even in patients where the Taxotere hasn't helped, this is a reasonable option. And as a result of this study, there have been a number of other studies done to try and bring this agent earlier into the piece. And the one study was called the Firstana study, which we were involved in, comparing this agent to Taxotere in the first-line setting. So what tends to happen is we show that the drug has activity in the second-line setting, and then we say, well, can we bring it early and see if we can improve the outcomes then? So really what this is showing is that as a result of another chemotherapy, we've got another option beyond Taxotere in that setting. The next treatment is the role of immunotherapy. And this is a study that I'm really just talking about more for interest rather than anything else. What the study done, it was not done in Australia, was where patients had some blood taken off, their cells were mixed with, in a process where you stimulated their immune system and re-injected the patients with that drug and some immune therapy. And that was done 3 times at 2-week intervals. And this was a controversial but very large international study. And this study also showed that there was a survival benefit when you used immune therapy. Now, there are a number of controversies with this study, but what it did show was that in some patients there was a benefit. It highlighted the fact that we can potentially use immune therapy in treating prostate cancer, that the disease is not just driven by hormones, that there is some immune component which is playing a role in this, and it's opened the opportunity to do a number of studies in that space. This drug is not going to be approved in Australia. I'd be very surprised. It costs about $100,000 for those 3 injections. And the benefits are modest. And there's a number of other options beside that. And there were also some controversies associated with the study. But it's a very important proof and expensive proof of principle. But this is a space that we should still be looking at. And it highlights now that we've got chemotherapy as an additional option, and now also looking at immune therapy. So a number of ways that we can try and target this disease. We should just spend a bit of time talking about the name, castrate-resistant, hormone-resistant, androgen-independent. And basically, there's been a lot of confusion about these names. And as it stands in 2013, the only correct term is castrate-resistant. And really what that means is that despite having castrate levels of testosterone, so despite having the testosterone completely suppressed, the disease is continuing to grow. Now that previously used to mean to us when we used the terms hormone refractory or androgen independent was that it meant hormones were out of the picture. Hormones don't work anymore. But that has proven not to be the case. And that's why it's so important to understand that the term castrate resistant is the correct term. And what that means is that even though you don't have testosterone, the androgen receptor, the hormone receptor, is still very important. And targeting that receptor is still an important opportunity. And that's where a lot of the future research has been, and that's where a lot of the excitement, and I'm sure you've seen a lot of publicity in the last few months about a new agent, Zytiga or Abiraterone, which has been recently approved. And what we know is that this is the androgen receptor, and this is testosterone. When it binds to that receptor, it fits nicely in that spot. It stimulates a whole lot of processes and makes tumors grow. But what that receptor does over time when it becomes resistant is say, well, we'll just multiply the receptors. So there's much more opportunity for testosterone to bind to it. So we can do things that target other receptors rather than just the one. The other thing that it does is it mutates, and then it says, well, we'll just use anything that looks similar to androgen, bind to the receptor, and the receptor will interpret that as testosterone and carry on growing. The other thing it will do is sometimes say, well, we're not even going to use testosterone. It'll just use any other hormone or any other peptide or any other protein to continue to grow. So what we understand by this castrate-resistant disease is that we're not just relying on testosterone anymore. And there's a whole lot of other pathways that can potentially be inhibited by manipulating this androgen receptor. And the advantage of these is that these are not chemotherapy drugs. So they've got a completely different side effect profile. And one of the most important drugs in that field is this drug called Abiraterone. And the reason why Abiraterone has been such an exciting agent is because, as we've talked about before, the drugs have previously just blocked testosterone from being produced in the testes and the other testosterone that's been produced in the adrenal gland. But what has also been very important is that the tumor cell itself is making its own testosterone. And it uses a particular protein to stimulate testosterone production within the cancer cell. So the cancer cell doesn't care what you're doing to the receptor on the outside. It's making itself its own testosterone on the inside. And that was a very important thing to understand, because now some drugs have been developed to target that protein which is making testosterone wherever it is, adrenal, testes, or most importantly, in the tumor cell itself. So this was a big leap of faith. And this study was a very exciting study to be involved in, where we looked at a number of patients who'd previously been treated with Taxotere and were then randomized to a placebo or this drug called Abiraterone. And that study completed about 2 years ago and was a very positive study. And this Abiraterone is just a tablet which is very well tolerated. It doesn't have the same sort of side effect profile as chemotherapy does, but has a lot of activity in this space. And this was a very exciting result. And as a result of this research, this drug was approved on the PBS in August of this year, and now is readily available in Australia. It's very well tolerated with minimal side effects, the main ones being a few abnormalities to the liver, some blood tests, and a bit of fluid retention, and also some blood pressure problems. The main problem with this drug is that you have to take it in combination with prednisone, and we can talk about that later if you want, where prednisone has some long-term side effects that we've just got to be a bit mindful of. So what we saw with this study was that it showed that there was a survival benefit. Importantly, there was a quality of life benefit, and importantly also an improvement in symptoms. It's a well-tolerated drug, it's oral, and the main issue was being able to access this drug. But fortunately in Australia, due to a lot of lobbying and a lot of people jumping up and down, it's now been approved, and I think that's a great result. One of the other questions has been asked, well, if we know it works after Taxotere, is there an opportunity to use it before Taxotere? And that study was also done, and it was done through this unit as well, and that did show a positive result. There's still a lot of controversies about the actual timing of when we should use that. In other words, should we be using it before chemotherapy? At the moment in Australia, it's not approved for that indication, or should we be using it after chemotherapy? And there's much debate about that. And I think the research still needs to come through about what the optimal timing of using these agents are. I'm just going to spend a little bit of time on one of the other agents called Xtandi or enzalutamide or MDV-3100. It's remarkable how they come up with these names. I was actually going to entitle my talk the XYZ of prostate cancer, because they all seem to be starting with X, Y, and Z rather than the ABC. This is an agent that works against the androgen receptor as well, but targets a number of pathways in the androgen receptor. I think suffices it to say is that this is another agent that is now targeting hormonal or the androgen receptor, and just highlighting that we can't ignore the androgen receptor in patients who've got castrate-resistant disease. The androgen receptor is still a pivotal part of making the disease grow, and if we can do things to target that, that's very important. Again, it's an oral agent, well tolerated. It's currently not approved in Australia, but that process is underway. So this is just what we call a waterfall plot, where we look at PSA responses in patients who have been treated with this treatment, and you can see that of all the patients treated, almost all of them have significant declines. Only a few % of patients didn't respond to this disease. It just shows the dramatic effect that you get with this agent. So in 2013, that's where we are. Many choices, many options, and it's actually quite confusing and difficult to know what is the best option for our patients today. And your oncologist or radiation oncologist or urologist will be weighing up all of these different options to work out how best to treat our patients. And there are a number of factors that come into it. Firstly is the timing. I think the important message from all of these targets that we've talked about, chemotherapy, immune therapy, and hormone therapy, is that almost all patients would benefit from having all of these options. The issue is the timing. What order do we use them in? The other thing that's becoming important is as we understand the biology of the disease, we are able to be a bit more selective about which patient should be treated with which intervention. So there's some diseases which are more likely to respond to chemotherapy, and other diseases based on their biology are more likely to respond to hormone treatment. So we'll hopefully be able to better understand which patient should be channeled or challenged with each one of those options. The patient and the patient's biology is also important. Obviously, toxicity and side effects are important. Clearly, the oral hormonal agents have a much better side effect profile than the chemotherapies, but the chemotherapy may be better for some diseases, and that's what the doctor's got to weigh up together with the patient. The important thing is how you sequence them, what order do we use the agents, and these are all the challenges that we're now faced with. And I must admit, it's a good challenge to have in that there are so many options. If you think back to just 7 years ago, we had one very average or probably even below average option. Now we have all of these options, and the issue is to try and work out who to treat with which agent and when. And obviously the cost is important, and clearly this has a major health economic issue for our health budget, and that's obviously very important. And I think one of the important issues that come from understanding the biology of the disease and selecting our patients more appropriately is that we're not going to be treating patients with drugs that they're not going to benefit from if we know that this is a patient who's not going to get a benefit from Taxotere, or this is a patient that's not going to get a benefit from drug X or Y. And that's what all of the research is doing now as well, is retrospectively going back to those studies and saying, well, what is it about the biology of these patients and these diseases that allowed this patient to respond to this drug and not that drug? So that's becoming very important. The other thing that I haven't talked about, and as I said in my first talk in 2005, I could have spent all day talking about this, but there's just not the time to talk about these issues, but it's not to undermine their importance. These are very important, is the importance of palliation and early involvement of the palliative care services to optimize symptom control. And sometimes people have a real misconception about palliative care, in that palliative care is for terminal care, and they certainly do look after that, and that's a very important part of the treatment. But palliative care teams also very important in managing symptoms and symptom control. And so early involvement of palliative care services are important. Radiation is essential, and there are a number of situations where we use radiotherapy to treat local problems, whether it be pain, blockages, obstruction, a whole lot of things, and radiotherapy is an important component of managing our patients holistically from a prostate cancer point of view. The other thing that we've got to also appreciate is the importance of bone health. As I said earlier, prostate cancer tends to affect the bone more than any other organ, and looking after the bone is important. And there are a number of drugs that are now available and that have recently been approved that we can use to try and help treat the disease in the bone and prevent complications in the bone. And there's a bunch of drugs called the rank ligand inhibitors, or drugs called denosumab. And also we'll touch on a little bit about this drug called alpha-raden, which is a very important drug that we should also just mention, which has just recently also been shown in a trial to be positive. One of the things that are happening, fortunately, with our patients with prostate cancer is that we're now starting to see our patients live very long with this disease, which now opens another can of worms for complications and potential problems, and that is this problem called the metabolic syndrome, which is a syndrome particularly for men who have been on androgen deprivation, or we've blocked their testosterone for many years, where they get this syndrome called the metabolic syndrome, which is a problem with blood pressure, cholesterol, lipid profile, and diabetes. And it's very important that this is identified and managed early in the piece. The other problem, and also things are done to minimize this, such as regular exercise and optimizing their nutritional status. And the other thing that happens is that with continued androgen deprivation or removal of the testosterone, is that we have an impact on the bone and bone density. And looking after bone health is also very important. And I may just mention this, the issue about LH-RH agonist therapy, the Zoladex, and whether we use intermittent or continuous is another very controversial area that is probably worth discussion on a case-by-case basis. I'll just briefly touch on this drug called alpha-raden, which is another interesting agent that particularly targets the bone. And just while we're talking about bone health, I think it's an important agent to talk about. It's just a study was done in Australia, and we were involved in the study, which has also shown a survival benefit. What this agent is a drug called radium-223, which is what we call an alpha emitter. So it's radiation therapy, but it's an alpha emitter. And what alpha emitters do is only emit radiation to 1 or 2 millimeters. So it's very focal and very localized. And what this drug does is has a specific affinity for bone metastases. So you inject this agent, and then it tracks down bone metastases, goes into the bone metastases, and emits a little bit of radiation just in the bone metastases. So you get a very focal treatment in the one area where you need it. So it has high efficacy and very little in the way of toxicity. And this study has also actually recently shown a survival benefit, and that drug has just recently been approved by the TGA. We're a bit further behind in Australia, but hopefully in the near future this agent will also be available. So the real challenges that we have is trying to work out who to treat and when to treat, and who we can afford to just watch and be a bit more cautious. And there are a number of factors that we look at, and each of your oncologists will be going through this in very close detail, weighing up all the pros and cons of treatment now, delayed treatment. What are the factors that are triggers to say, well, look, we need to get on with it now or not? And these are some of the things that we look at. So the future is very exciting. We know that progress has been made, and this is the list of drugs that in the last 3 or 4 years have been approved. We know that combinations with biologics are interesting, but to date haven't been shown to be effective. But we know that the sequential use of the drugs is important. We've opened the opportunity for options in the second and third line treatment, and there are a number of drugs that are being looked at in that area. Now that we know that there's a bunch of drugs that are active after chemotherapy, what about bringing those drugs earlier? And there's a number of trials looking at that now. The priority is to make sure that our patients can access these agents. And obviously some of that comes through doing clinical trials which show the activity of these agents, and then hopefully go through the relevant channels to get the drugs approved. But clinical trials are very important, not only because they have been the things that have moved the frontiers in how we treat this disease, but also it's a way that our patients can access drugs now that would otherwise be unavailable. The real push needs to be on appropriate patient selection for the appropriate treatment. And then again, just to plug the importance of clinical trials. So I may stop there. I'll just highlight what we had in castrate-resistant prostate cancer in 2006. So in patients who had no metastases, there was no standard treatment available. All we could offer those patients would be clinical trials. In patients who had low volume metastases, all we could offer our patients were Taxotere or a clinical trial. In patients with metastases, all we could offer was Taxotere or a clinical trial. And in patients with second-line disease, nothing. This is what we have 5 years later, 6 years later. Patients with no metastases, there are a number of clinical trials which are progressing and are very worthy of consideration. This is what we have available for low volume metastases. You remember we just had Taxotere before. This is what we have for patients with metastatic disease. And this is what we have in the second and third and fourth line treatment options. This is just in a short period of time, a dramatic change in what's available. And that's a very exciting time. Now, obviously, we've still got a way to go. We're still not eradicating the disease, but we've certainly seen major progress in the last few years. So this is a slide that I was given. In your case, Dave, there's a choice: elective surgery, outpatient medicinal therapy, or whatever's in the box that our lovely Carol is holding. And we're now starting to understand a bit more about what's in that box and who should have what from which box. So the take-home messages, as I said in the beginning, the first thing is that prostate cancer is not one disease. So it doesn't matter what your next door neighbour has. It doesn't matter what it says in Women's Day or the Sydney Morning Herald. It's a completely individual disease that is assessed on a case-by-case basis. It's individualized treatment based on patient and disease factors. It is very clear, even though I have a bias in this disease, I think you'd all have to agree that progress has been made. Now the challenge is how we integrate some of these novel and targeted treatments into our day-to-day practice, and again, just to highlight the importance of the clinical trials. And I'll just finish with a slide that one of my patients gave me, and I think that's a very important message. We mess around about all the importance of clinical trials, but the patient itself is obviously very important. And she said that the big C obviously hasn't heard of the big me, and the patient in this whole issue is very important, and their involvement and their commitment is something that really does make a difference to our patients' outcomes. I'll stop there.
I'm sure there'll be some questions. My wife Margie's got a microphone, so if you could speak into the microphone when you ask the question so that you can go on to the video.
Thanks very much for the talk. Being a little bit of a newcomer to the prostate cancer business in the last year, I found that one has to do a lot of reading, and one gets a chance to have a surgeon have a particular outcome with that, and go a certain distance with any additional treatment. I guess the question for me is that at what stage does one seek either second opinions or further opinions to get a different perspective on the cancer-specific issue that one has?
So I think the first thing is to understand about, we all have different roles in the whole management of prostate cancer, and I think it's very clear now that prostate cancer is managed in a multidisciplinary modality. So most hospitals, and we have one here, you have a multidisciplinary meeting where there's a collection of pathologists, radiation oncologists, radiologists, but the medical players, which is the urologist, the radiation oncologist, and the medical oncologist, all play an important role, and we try and provide a multidisciplinary approach to an individual. But clearly, at different times of the disease, there are different players involved. Now, in the early stage disease at the time of diagnosis, and really at this stage, it was very clear that people like me, medical oncologists, really don't have a role. People like don't have a role. But that role, depending on where you're at, is either a radiation oncologist or a urologist or a combination of the two. And often patients will flick between the two depending on what sort of treatment is required at the time. This is, in the past, medical oncologists used to get involved maybe there. We didn't really have a role because we didn't have much in the way of treatment. But in the last few years, we started getting involved over here. But what's happened now, because of all of these newer agents, which are now starting to be looked at earlier and earlier in the piece, most urologists who are involved in multidisciplinary meetings will start referring patients a bit earlier, after the first lot of hormonal manipulation has stopped working. So the first issue is, when do the different players have their biggest role? And obviously the urologist and the radiation oncologist tend to be involved earlier, and we tend to be involved a bit later in the piece, but earlier than we previously used to be involved. But even when you're involved at this stage, there's still a very important role for the urologist and the radiation oncologist. And I think the key is to make sure that you've got a team that all work together, and the patient should be flicked between the three of us, the three specialists, depending on what the need is. So, there's one person who'll be owning the problem predominantly at the time, but needs to have a very close working relationship with the two others so that the patient is appropriately switched between the three of us depending on what's needed at the time. So I think that's the first issue about the different players. The next issue about a second opinion, it's always hard to know, when you should get a second opinion. I think if you feel uncomfortable with a particular decision, there'd be no harm in having a discussion with someone else. I don't think, a lot of the time second opinions don't really change very much from what the person you're seeing would discuss, particularly if there's someone who's actively involved in the management of prostate cancer. I think, people would generally follow the consensus, follow the guidelines as to what's the most appropriate treatment. But it is important to know that there are some issues today that are quite controversial. And what the best treatment is is controversial, and that means that there are 2 different options or 3 or 4 different options. And sometimes it is worth just chatting to someone else just to get a different perspective. But at the end of the day, it ends up coming back to the patient, after you've been well informed about what the options are. The one thing I would say very strongly, though, is that the worst place to get a second opinion is at the golf club or at the bowling club or at the hairdressers. Because without someone sitting and knowing all of your information, it's irrelevant what they tell you. They might as well talk about diabetes or hypertension, because as you can see, this is such a complex field. Unless you know what the scans look like, what the pathology looks like, you should ignore them. And unfortunately, people are very forthcoming with very little information about the best advice. And I think that's the time that I spend most time picking up pieces, is that patients come in and say, well, my mate said I should be having this. Mate just has a friend who's got cancer and has suddenly become an oncologist. So you've got to be careful with that. So I think selective second opinions are appropriate, but not from family or friends.
Yeah, I guess it's not so much having a second opinion on the advice that is given by a particular specialist.
Yeah.
It's actually getting the additional perspective which may be offered by that other specialists in that patch. Well, like I'm in that MO area.
Right. So, I mean, generally what happens is, particularly if there are people involved with the multidisciplinary team, even if you're seeing a radiation oncologist or a urologist at this stage, part of their responsibility and part of their job, and they would generally know that, look, this is the time that we need to start looking at options with chemotherapy or clinical trials. And so they would also be the trigger to say, well, it's now time to see my colleague who's a medical oncologist. And that's what they would do. And this is also something that's changed in the last few years. And when Castrate came on the market, a lot of urologists weren't referring patients on for systemic treatment because it was new. They weren't involved with those trials. They didn't know about it. That's changed. And so now, pretty much, I mean, everyone would know about it. They would all know that, look, this is the time to start getting my colleagues involved in different subspecialties. So I think if you're asking who makes the decision when you need to see a medical oncologist or when you need to move on to seeing the next subspecialty, generally the person who's owning the problem at that time would be the one who directs that. And in most situations, that would be done in a timely fashion. And sometimes it may be something that's worth asking, should I be seeing someone at this stage? And they would have the answer for that. And, it's not going to be relevant to see a medical oncologist here, but somewhere along there, it probably is.
Yep. Yeah, thanks for a great talk. I'm still very, very new to this, but I just wanted to ask about the, you mentioned it's a heterogeneous disease. Is it the only cancer that is that, or
No.
other cancers, other diseases as well? And what makes it, or why is it heterogeneous?
So most cancers are heterogeneous, and so probably the same rules apply. Just a breast cancer, for example, there's a whole spectrum of disease within breast cancer, and it's pretty much the same with most diseases. I would think that of all the diseases, though, the widest spectrum of heterogeneity is probably with prostate cancer, and it's probably also the group where there's the most confounding factors, because generally it occurs in older people where there's a number of other comorbidities. But even in a younger patient group, there is still quite a wide range of disease behaviours and disease biology. And it is different, in other tumour groups it's the same. Now, what drives the heterogeneity is where there's a lot of research at the moment, but there's a number of factors that we understand would be contributing. And the first thing would be is what component of the tumour growth is driven by hormones. So what component of the tumour growth is driven by the androgen receptor? What component is driven by genetic mutations or other problems that are causing some of those other factors that I showed you in that graph of the androgen receptor? And there are some things that we just don't know what the triggers are, but there are factors in the Gleason score that tell us, well, this is a more biologically active disease. What is it that makes a low Gleason score and what is it that makes a high Gleason score is not clear, but those are the factors that sort of will affect the heterogeneity. But it's a problem that we have. Well, it's the reality of cancer across the board is that it is very heterogeneous. And one of the other challenges that we're starting to see is that even within metastases, sometimes there's some heterogeneity as well. So in other words, there'll be some areas which will respond to a particular treatment, whereas other areas continue to grow or are stable. And so we now have to use different treatments for different parts of the disease in the same patient. So it is becoming very complex and very difficult, and there's a lot of factors that we use to try and help us understand who should be treated with what treatment and what component of the disease is biologically very active and what patients need to be on, more urgent treatment than others.
I'm a bit naive, but this word heterogeneous, what does it actually mean?
A mixture. So homogeneous is if everything is the same, all of the cells are the same, or all of the disease is all the same, everyone's behaving in the same way. Heterogeneous is when you've got a wide spectrum of behaviours. And what it is, I'm sorry for not clarifying that in the talk, but what it really means is that within the disease itself, there are some patients, within the big heading of prostate cancer, there are some patients who've got just slow-growing, biologically inactive disease that just will grumble on and never cause a problem. And other patients who still fall under the heading of prostate cancer will have a very aggressive, biologically active disease that without treatment is going to cause significant life-threatening problems in a short period of time.
Combination of a number of things.
Yes, yeah. And then there's a whole lot in between those two.
Thank you very much.
Just a question on pathology after, let's say, prostatectomy. And is there any opportunity to actually put drugs into the, whatever they've cut out to see what reaction might or might not occur?
Yeah, so that's an excellent question. It's actually not exactly like that, but in clinical trials at the moment, one of the areas that is of most interest for research is to give patients there's not a lot you can do once you've had the prostatectomy because there's not a lot of viable cells. But there are some biologic tests that you can look at on the tumour specimens or on blood specimens, certain proteins and circulating proteins that people are doing research on, and we've been involved in some of those trials where you try and say, what is it about is there something that predicts who's going to respond to which drug and who's going to respond to another? And that's one of the things that have been done retrospectively, with the benefit of hindsight in studies. So we've seen that a patient's been on a particular drug, this patient responded well, and we do a whole panel of markers or proteins or nucleotides on the blood and see which correlates with what. So that's one area that's looking at it. But one of the areas that's very interesting, and there's a lot of research in other diseases as well as prostate cancer, is to give patients to do the prostate biopsy and then give patients a particular treatment and see what happens. And then you look at the tissue. And so that tells you whether this is the sort of patient that's going to respond to whatever treatment you gave before. But there's a few ethical questions and appropriate questions that you need to ask with that. Obviously, if someone has got early prostate cancer where the best treatment is just to remove it, you don't want to be messing around doing other things while you're waiting. The time that people are looking at that is for people who've got locally advanced disease where the best treatment wouldn't necessarily be to remove it straight away, but you need to do some things to shrink it down. And so there are some trials looking at giving what we call neoadjuvant or pre-definitive treatment therapy. And then that's a very good opportunity to look at the pathology and say, well, how did this person respond? And then that has an influence on the treatment decisions you use down the track. So if you'd use Taxotere for argument and the patient had had an excellent downstaging or shrinkage of the disease, you can use that drug down the track and vice versa. Now that's done a lot more in other diseases, particularly breast cancer and colorectal cancer, but there's a number of studies looking at that in prostate cancer. One of the challenges with those studies, and a number of studies in that space have actually closed because accrual or getting patients on the study is so slow and so low, is because patients don't like to just sit around waiting for a treatment to see whether it has an effect or not. They want it out, or they want to treat it with radiotherapy. So it's a very good and it would be a phenomenal scientific question, and I think it would advance our knowledge significantly, but patients have to buy in on that, and it has to be ethical and appropriate at the time. But that's certainly an area of active research. Excellent question.
What does the patient have to come to you with information-wise, and what tests can you give that patient? In what are the choices of tests that you give?
Again, it depends on what the situation is.
Right.
So the main thing that a patient would need is obviously a referral, and then if it depends where the disease is at, but we would always need to know what the pathology was like, because as we've talked about the heterogeneity of the disease, having a diagnosis of prostate cancer doesn't really tell you much about the disease. So you'd need to have a look at the pathology report, and sometimes we even review the pathology in our multidisciplinary meeting to say what's the nature of the biology, what's the biology of this disease, what's driving this disease. And then you also generally need to understand what's happened to the PSA over a period of time. You also then need to know what other treatments patients have had along the way, so that you can say, well, it's responded to this period of time to a particular hormone treatment, or hormone treatments have been completely ineffective in this guy. I'm not going to carry on with hormones. So, you need to know the timing and the sequencing of the different hormone treatments that patients have had. And then you also need to understand the extent of the disease. And the way that we understand that at the moment is by staging investigations. And you want to stage the most common places for metastases. So obviously we do a bone scan and look at a CT scan. Now, sometimes patients come with all of that information, and sometimes that information is not quite relevant or not quite necessary at the time. But if that's stuff that the oncologist would need to make a decision about the next treatment, then we would do those tests. So it depends on where you're at with the disease, what tests are needed. But generally, coming with that information would make it easier. But in a lot of cases, patients don't have all of that information, and so we'd have to reassess. And obviously, you also need the information about the other medical problems of the patient, the other general well-being, so that we know what's a competing risk, whether prostate cancer is ever going to be a problem or not.
Thank you very much.
Can I just ask a question? This is a terribly personal question, and it crosses my mind regularly, but wouldn't the removal of the testes be relevant to this? Then you're not producing testosterone?
Absolutely.
And why isn't it carried out more before men are taking a lot of these drugs?
Yep. So that's a very reasonable question, and the standard of care for getting patients to be castrate resistant is two choices. The one is you can remove the testes, and that's a very effective, efficient, cost-effective way of dealing with the testosterone level. And the other way is to give the injection once every 3, 4, 6 months, depending on which brand you use. They both achieve equal levels of testosterone reduction, or almost equal. It's probably better with removing the testes. You're still not accounting for that small amount of testosterone that's produced by the adrenal gland. Definitely the most cost-effective way of dealing with it. The problem is that it's a difficult thing to negotiate with men, and a lot of men don't want to do that, because the other problem with it is firstly the appearance, although you can use prostheses, but the other problem with it is that it's permanent. You can never reverse that. So one of the ways of testing that in a man who may elect to have we call it an orchidectomy, where you remove the testicles, is to give them a period of time on the injection, so you can see how you respond to not having testosterone. And if it's a disaster, then you've still got the opportunity to reverse that by stopping the injection. But definitely doing the orchidectomy is an option. And in some countries where the drugs that we use, the 3-6 monthly drugs, are very expensive drugs, and in some countries they say that's not an option. Do an orchidectomy. It's a much more efficient, cost-effective way of dealing with it. Yeah.
Okay, then I think we'll call it quits there and let Gavin go home. I'd like to give you one of our barbecue kits as a small token of our appreciation.
Oh, thank you very much.
Again, Gavin, thank you very, very much. It's always such an inspiring talk. There's always so many new things that are coming on the scene to look after the chaps with advanced prostate cancer, and we always enjoy your presentations. I'd like you to thank Gavin. Thank you very much.
Thank you.